Sumit, please. So he will not do needling. He will do Re-Trab or AGV. Dr. Sumit, please.
Thank you, Ajanta, and thank you, Rajul and Shefali. But I don't know what harm I have done to him because he put me in the cage with one of the great warrior, Rajput warrior from the Rajasthan, who used to fight with swords and other thing. Now he's fighting with a needle. Only 26 gauge needle. Okay, just jokes apart. Just yes, I do confess I do needling in the initial phases of any failed trabeculectomy, but not always it acts. So managing the failed trabeculectomy, my choice is in the long run, it is trabeculectomy or the tube. The introduction and the clinical dilemmas. Initial trabeculectomy failure rates increases over time is about 20 to 45% 5 years to 10 years period. So primary, what is the primary culprit? Subconjunctival fibrosis and bleb scarring. In the subconjunctival fibrosis, it is the initial set needling works much better. What is the intrascleral, subscleral? It doesn't work much better. The next challenge steps comes to choosing the secondary surgical intervention. And the key consideration factors should be target IOP, remaining the congenital health, lens status, and the patient risk profile. Option 1, trabeculectomy. Overview, performing a second trabeculectomy at a new surgical site, usually the superior nasal or the superior temporal, where there is a good conjunctiva is there. And the advantages are there. Familiar technique for most of the endo surgeons can achieve very low IOP and no foreign body implantation if it is required or not. The next option, the tubes. Overview, placement of a tube shunt in the anterior chamber or the ciliary sulcus. The advantages, less dependent on the local conjunctival healing or the antifibrosis, more predictable long-term IOP control, highly scarred eyes, scarred conjunctiva mostly, and the lower risk of the bleb-related infections. So retrabeculectomy limitations and risks are always are there. Disadvantages is the high risk of recurrent episcleral scarring. Conjunctival scarring severely limits the future surgical options. Complication may arise in the early post-op hypotony, bleblix, blebitis, etc. And the best suited for patients needing very low IOP with localized previous scarring and healthy remaining tissue is there. Then comes the sun, which may be AMAT or the RD to 350 or 350 or 250 on the clear path. The near what? It's a two types. The valve shunt, the AMAT one, immediate post-op reduction is there, lower initial hypotonic risk, but higher rate of hypertensive phase weeks later, it found. So he had to give some little bit anti-glaucoma medication. The best choice should be the non-valve shunts, the RD or the clear path. It requires the temporary occlusion with the ripcord or the ligature sutures to avoid the early hypotony, and it achieves the lower long-term IOP compared to the valve one. So what does the evidence says? The TVT study, 5 year outcome, failure rate at TVT, group group 33% by the trabeculectomy with FMC, 47%. IOP control, both groups achieve the similar IOP and the long-term effect. Supplementary medication, slightly higher numbers recorded in the two groups. Complications, early complications were higher in the trabeculectomy and the late complications were similar in both the groups. The arguments in favor of the retrabeculectomy over needling, lower achievable IOP with a new filtration pathway and fresh antimetabolites, better long-term success than needling in appropriate cases, addresses extensive scleral flap or the conjunctival scarring, and reduces the repeated procedure needing for the needling. In favor of the tubes, bypasses the conjunctival fibrosis, higher long-term success, predictable IOP control, and less dependence on the postoperative bleb manipulation which is required. So limitation of the needling. Best only for the early bleb failure with minimal fibrosis. Ankur has given a lots of evidence base, but it's practical. In my part, I found it's quite difficult in the long-term cases. It fails, but it stays also. So lower success rate in long-standing scarred bleb, often requires the multiple procedures, risk of recurrence occurring, and less likely to achieve the low IOP, and less suitable for the advanced glaucoma, where low IOP is needed, and less predictable outcomes. The conclusion and clinical summary: there is no one size fits all approach in managing a failed trabeculectomy. Tube shunts offer a significantly high cumulative success rate and structural durability over the 5 years period. Retrabecularity remains the powerful when aggressive lower ultra low target pressures are required. Alternative procedures are also there. Thank you very much.
Yeah, thanks, Dr. Sumit. So the last talk of the session, Dr. Chandrima will talk. Okay, till the talks get loaded. Dr. Rita, if you and Sneha, both of you can answer. We have a TVT study, we have PTVT study. How much of the both study the information you use for the clinical practice?
I think, I have never done a primary tube at all. So I am not one in favor of doing a primary tube at all, even if it is very advanced glaucoma. I always give trabeculectomy a much, much better chance than going ahead straight away.
So primary tube has a very specific role in some form of secondary glaucoma.
Now, in other cases, if now it is a retrap that we have to do, supposing you have a failed trap, then whether to do a retrap or whether to do a tube is a question that we have to think about. So, when will you do a tube when you have no good conjunctiva left? The entire, conjunctiva could have got scarred. There could have been a lot of adhesions between even the neighboring areas of your existing tube that trap, so that you have no chance of doing another trap and expecting that it is going to succeed and stay patent for a long, long time to come. So that is a time when I think the tube does wonderful. And of course, you have to keep following it because we know that
Sure.
everything has its
So
own.
you agree, Sneha, or anything else you want to add?
I agree, sir, but yes, there are certain very specific cases. Even if the conjunctiva is to scarred with begin, I have done a primary tube.
Yeah, the
So
specific conditions.
there are certain.
If the sclera is thin,
Yeah,
is
those
all the
if the patient
specific
has
specific
OCT or
condition.
something
Yeah.
like that,
Okay, fine.
primary.